Hi, everybody. Good afternoon. Of course, I would like to begin by thanking Manos and Manos for this kind invitation. I'm very proud to be here among this prestigious faculty. So my task is to talk a little bit about the natural history of a rotator cuff tear. So I have no disclosures. So actually, what is the natural history of a rotator cuff tear? Is it what happens until the rotator cuff tears? Is it what happens after the rotator cuff tears if we don't do anything? Is it what happens if we treat them conservatively? Is it what happens if we treat them surgically? And why is this important? How can it be applicable to our day-to-day practice? So back in 1963, Dr. Carter Rowe said that the majority of the rotator cuff lesions should respond satisfactorily to conservative measures, noting two exceptions. One, the young adult with a documented full-thickness tear, and the other one, an elderly patient with a full-thickness tear with disabling pain, unresponsive to conservative treatment. So after almost 60 years, where are we now? We have a lot of new information, a lot of evidence-based information, and it gets a little confusing. So in order to organize all this information and make it applicable to your day-to-day practice, you can try and organize it like this. You have to think, who's your patient? And second, what is the type of tear? And third, what is your goal? And not just you as a surgeon, but your goal with your patient. So first, the patient-related factors. So we know that male gender, dominance, age, heavy labor are related to a greater development of rotator cuff tears, and that in patients with more than 60 years, there's a 4 times greater tear progression than if the patient is less than 60 years. We also know that dominance is related to tear enlargement, and if you have a painful rotator cuff tear in a patient with more than 66 years old, there's a 50% chance of him or hers having a contralateral asymptomatic rotator cuff tear. So this is very important to tell your patient. And secondly, what is the type of tear? You can have a lot of type of tears, of course. You can classify them according to the timing. You can have acute traumatic tears. You can have chronic degenerative tears. You can have acute and chronic. Or relating to their size, you can have a partial thickness, full thickness, a massive tear. You can have an asymptomatic tear, you can have a symptomatic tear, and if it's symptomatic, you can have a painful tear, you can have a tear when you have loss of range of motion, you can have loss of strength. So there's a lot of natural histories here. So let's try and organize this a little bit. So first, acute traumatic tears. So we know that there's an acute shoulder trauma, which results in a limited painful range of motion in a previously asymptomatic patient, right? The information actually is very sparse in the literature. You have some papers who state with a low level of evidence, with level 5, that in patients young and in the acute, in patients young and active, the acute tear should be treated surgically, should be repaired. Since 1983, there's a few more papers published. The only thing that I could gather from these papers is that the mean age of acute traumatic tears is about 54.7 years old. They're highly related to the loss of the ability to abduct the shoulder above 90 degrees. About half of them have 2 or more torn tendons. 78% of them have more than 3 centimeters, and they're more likely to involve the subscap than chronic tears. In 2019, the Acute study group published this protocol, so maybe soon we'll have some good results. How about chronic degenerative full-thickness tears? No history of trauma. We have a progressive tendon degeneration related to an altered shoulder biomechanics. We're trying to understand more and more about scapular dyskinesia and how it affects the tendon degeneration. So what we know is this happens in the patients almost 10 years older than acute traumatic tears. Dr. Kim in 2010 analyzed 272 patients by ultrasound, and he concluded that just one third involved the anterior cable, and the most common location of the tear was 13 to 17 millimeters posterior to the bicipital groove. He could relate the disruption of the anterior cable to supraspinatus degeneration, and the larger tear size was the most common predictor of infraspinatus degeneration. He also concluded that fatty degeneration occurs almost exclusively in full-thickness tears. In 2011, Dr. Safran and colleagues evaluated 61 full-thickness tears by ultrasound also with a 2-year follow-up. They concluded that 49% enlarged, and they could relate tear enlargement with pain development. In 2015, Dr. Keener and colleagues evaluated 118 full-thickness tears by ultrasound. They concluded that at 2 years, 22% enlarged, at 5 years, 50% enlarged, and tear enlargement was correlated with pain development and fatty degeneration. Also, they concluded that about 46% of asymptomatic tears develop pain in 5 years. They become symptomatic in 5 years. Another study by the same year, by the same leading author in another journal, they evaluated 139 full-thickness tears by ultrasound with a 2-year follow-up. They concluded that there was a tendency to greater enlargement in cable-disrupted tears, and they also could correlate pain with decline shoulder function. In 2017, Dr. Herbert Davis, he evaluated 156 full-thickness tears by ultrasound with a mean follow-up of 6 years. They concluded that 67% enlarged. Tear enlargement was correlated with fatty degeneration, and the time to degeneration was a median 2 years for supraspinatus and 3.1 years for infraspinatus. In the same year, Dr. Moosmeyer evaluated 37 full-thickness tears by MRI with a mean follow-up of 8.8 years. They concluded that 50% evolved to a positive tangent side, and they could correlate the positive tangent side to an inferior function in relation with the constant score, AZ score, and strength. So how about partial thickness tears? The mechanism is the same as full thickness. In 2010, Dr. Kim, the same study presented previously, 88 rotator cuff tears using ultrasound, most common location 15 millimeters posterior to the bicipital groove, not so different from the full thickness. In 2015, Dr. Keener, 56 partial tear thickness evaluated by ultrasound. At 2 years, 11% enlarged. At 5 years, 35% enlarged. In 2009, 49 rotator cuff tears evaluated by MRI, 0% no fatty degeneration in partial thickness tears. In 2010, Dr. Moll evaluated 30 partial thickness tears by ultrasound with a 2-year follow-up. 20 remained asymptomatic. 10, about 1/3, 30%, progressed to symptomatic, and of these, 40% progressed to full thickness tears. So how about acute on chronic? So theoretically, you have an acute shoulder trauma, but with a previously symptomatic patient, and with probably a contralateral rotator cuff tear also. So there's not a lot of information, just to say none, about this kind of tears. There's some mentions in some papers, but there's a lot of lack of evidence. It's difficult to study this kind of, and to separate this kind of patients, of course. We know here the central role of MRI. If you have an edema on a fatty infiltrated and muscle atrophied muscle, and a muscle atrophied cuff, you probably have an acute on chronic tear. So should we treat them as acute? Should we treat them as chronic? We have no evidence. So the last but not the least, what is your goal? You want to treat pain? You want to restore some function? You want to restore perfect function? Do you want to gain strength? Do you want to return to sports? Do you want to return to manual or heavy labor? And this answers this question, why is this important? This is important for you to adjust expectations with your patient from the beginning. You try and have a shared and informed decision in order to obtain an optimized outcome. So after all this, if we squeeze this orange, what do we have here? So we know that acute traumatic tears affect patients about 10 years younger than chronic degenerative tears. Acute traumatic tears usually involve 2 or more tendons, and one of them is probably the subscap. Half of the patient with painful degenerative tear have a contralateral asymptomatic tear, and half of the asymptomatic rotator cuff tears become symptomatic in 5 years. Less than 1/3 of degenerative partial thickness tears progress to full thickness tears. Degenerative partial thickness tears have less tendency to enlarge than full thickness tears. Fatty degeneration affects almost exclusively full thickness tears. Just 1/3 of the full thickness tears involve the anterior cable, and the anterior cable involvement is related with a faster fatty infiltration. If left unrepaired, half of the full thickness symptomatic tears enlarge in 2 years. Tear enlargement will lead to progressive fatty infiltration in approximately 2-3 years. Tear enlargement results in painful shoulders, which result in decreased shoulder function. So as my take-home message, I want to pass this. There are many natural histories of a rotator cuff tear. You should identify them, know them, and explain it to your patient. Understanding the natural history of your patient's tear will make us better doctors, I'm sure, and explaining that their specific natural history to your patient will make him surely a better patient. Thank you.